Hello everyone. Hope you enjoyed the workshop from Mr. Benjamin Schumann. And now I'm pleased to introduce you again, Mr. Ahmed Alamed from Lean Business Services, who will tell us about the emergency department crowd and decision analysis. Welcome.
Thank you. Hello once again. Once again, my name is Ahmed. I'm from Lean Business Services. At Lean, we provide business solutions to the health sector in Saudi Arabia. And today we're going to talk about the emergency department simulation. So in most hospitals around the world, there's a problem with patient crowding and patient waiting time. Sometimes hospital would take multiple different decisions. The management of the hospital would take multiple decisions to decrease patients' waiting time and the patients crowding. And sometimes there would be crowds. Sometimes other times the ER department would be free or available. So the management of the hospital would take multiple and different decisions to decrease that waiting time, and most of these decisions are based on their experience, but not many of them are based on science and simulation. So instead of taking decisions that might cost, such as building an entirely new building for respiratory zone, which cost a lot. Some other policies might be risky, especially since we're dealing with ER patients that need emergent help, and the longer the patient waits, there might be more complications. So some of them are costly, some of them are risky, and instead of implementing these decisions in real life and taking the risk in real life, you can test it first on the simulation. So basically, we built a discrete event simulation to help us in the following. Since you have crowding in a hospital, there would be multiple problems. First of all, the patient length of stay would be high if there is patient crowding. So the patient length of stay, the time from the beginning of entering the ER department until the patient gets the entire treatment and until he leaves the ER department or the hospital. If there is a crowding, the average length of stay will be high. Another problem is that the patient waiting time would be high as well. The patient will be waiting more time than expected or than normal in cases where there is crowding. Another problem is that, as I mentioned briefly before, increasing patient complications. Some cases are severe and they can't wait for too long. The longer they wait, the more complications there will be. So with crowding and with increasing waiting time, there will be more complications. Last but not least is the healthcare quality would decrease in case of ER crowding. So we built a simulation model to help us in the following: assisting emergency department managers and decision takers to make the right decisions by analyzing and evaluating different scenarios before implementing them in real life and taking the risk in real life. We can test them first on the simulation. Another thing that the simulation can help us is identifying the full capacity limit in emergency department, even if we don't need to add a new scenario. We just need to know the full capacity of the hospital. The simulation can help us in identifying the maximum capacity. For example, the maximum number of patients per hour. What would happen if more than the maximum capacity, the expected maximum capacity of patients come to the hospital? What would happen? Would the hospital be able to operate as expected or not? Another thing is the identifying root causes of ER department problems. With so many different tracks in the hospital, so many different patients, so many different resources in the ER department, it would be very difficult to identify the problems where exactly the which department or where exactly we need help in, to decrease the crowding in the patient in the ER department. Simulation can help us in identifying where exactly where the problem is exactly. Another thing that could help us in is identifying areas of improvement, where exactly I can improve or change to decrease the waiting time or patient crowding. In addition to decreasing patient waiting time, once we test different scenarios, we can know which scenario is the best, so we can help in decreasing the waiting time. In addition to understanding and raising the resources utilization. For example, if one unit, a bed is not fully utilized, we can transfer that bed to another unit to maximize the utilization of resources. Similar to the health resources, in addition, the staff or the human resources in the hospital, such as nurses and doctors. If there's a crowd in one unit, but free time for other health resources in other units, we can the simulation can help us in health resources allocation to see how can we best utilize our resources. So before we started building the simulation, we basically went to an ER department in Saudi Arabia, and we for 10 days to approximately 10 days we studied the flow the flow inside the ER department, how the patient arrives, what are the steps that he has to take. The nurses and the doctors, how they interact with the patient, and which areas there are in the ER department, and so on. So we started building a simulation that mimics or simulate the exact same behavior as we observed. In addition to, we collected historical data from 2 years of that hospital to input the parameters or the numbers that the hospital operates on a daily basis. In addition to, we got the ER blueprint to draw or to simulate the exact same floor plan of the ER department with the same dimensions, same number of meters from the door to the reception area, and so on. And then we built the simulation to simulate the patient and the other health resources in the ER. So there are 2 types of patients that enter the ER department. First part is, or first type, walk-ins, people who come with their cars and just go to the ER department, and they could be adults, there could be kids, and then based on their demographics and the criticality of their case, first they will enter the ER, and then they will do a visual triage, which is an automated self checkup, where the patient himself fills a quick survey to help the hospital understand the criticality of the patient. And then based on how critical it is, the patient would either go to waiting area until he's called by a nurse, and then go to a triage area where they can take his or her vital signs until they go to the treatment area, whether it's critical care, acute care, or whatever that patient needs. In addition to the walk-ins, some patients enter the hospital by an ambulance. An ambulance will come, and a staff will take that patient from the ambulance and admit him to the ER. And then similar flow will go based on the criticality. The patient will be admitted to the specific or the needed unit in the hospital, in the ER department. In addition to the model, there are multiple scenarios that are built in the model. Some of these scenarios are just minor changes, such as changing the rate or the number of people who would enter. Other scenarios are actually entirely new model that is connected to the actual model. Based on the complexity of each scenario, minor changes will be added to the or complex changes will be added to the original model, and we'll come to each scenario shortly. The output of the model, there are multiple parameters or KPIs. First of all, the average length of stay. As we mentioned, the length of stay from entering the hospital until leaving the ER department. In addition to average utilization of resources, human resources or other health resources such as beds and ventilators and other health resources. The average waiting time and the average health resources utilization, and the utilization of doctors, nurses, beds, rooms. In addition to we're reporting the length of stay distribution by each unit and the waiting time distribution by each unit in the ER department. And finally, the number of patients, whether from the beginning of the model or at a specific point in time. So the model is built with a user-friendly interface that we will show shortly. This interface will help the ER department to test different scenarios, a combination of multiple policies, and if we hit run, you will see the exact same floor plan in the ER department that we visited, presented here, and the exact same flow as the patient. Once the patient enter the ER department, they go to the visual triage, and then they will wait in the waiting area, where a nurse will come and call their name, and then both of them will go to the triage area where they check the patient's vital signs, and then based on the case or based on that patient will be admitted to one of these units. If the case is very critical, the patient will go to the critical care. If not, they will go to the acute care. If the patient is a kid, they will go to the pediatric acute care. And if the patient has an infectious disease, they will go to the respiratory zone. And in case the hospital reached a capacity or reached a large number of patients, an extension area will be opened. So if there is a need to use more beds, the extension area will be utilized, and then you will see some patients entering the extension area. As I mentioned, some patients come by walk-ins, others come in an ambulance. We might see, yeah, here, this is an example of an ambulance that just dropped a patient, and then the patient is admitted to the critical care in this case. And then here we can see the number of patients in each unit at any point in time, whether it's right now or since the model started. Next, we can see the dashboard where we can see all of the KPIs, starting from the average length of stay, which is one of the most important parameters here. There is a KPI of around 4 hours length of stay. So if the hospital does not meet that KPI, we can know specifically, or we can track specifically which area caused that high number of average length of stay. We can click, for example, the acute care, and in the acute care, we can know the length of stay distribution, in addition to the percentage of patients in the unit from the total patients in the ER, and in addition to the utilization. And in that unit, we can see what would happen if we add one nurse. How would that impact the average length of stay? In addition to the average length of stay, we're reporting the average waiting time in the ER department, as well as the average utilization and the distribution of utilization of each type of health resources. Similarly, you can see the same statistics in each unit. And once, in addition to the dashboard, we can see the what-if scenarios. So as I mentioned, some scenarios are very simple, such as, it's simple yet effective. One problem that many ER departments face around the world is that a lot of the patients that goes to the ER department, they don't really need the ER. If they go to the primary healthcare, the primary healthcare can deal with them. So one scenario would be transfer patients who do not need urgent care to the PHC. We can click it and see what would happen. This would change the model. We have a statistics from the historical data that tells us how many per day how many patients per day come to the ER department that are not in need of ER. And based on that rate, once we check that scenario, basically some of the patients will go to the reception, and the reception will not admit them, so they will just leave the ER department. This could impact the waiting time, but it could not. Possibly that the number of people who do not need urgent care in one hospital is not high, so it wouldn't impact the crowding or the overall average length of stay. But there is a scenario that can test that. In addition to, another scenario is using urgent care clinic at peak times. Another scenario is installing virtual clinics to perform initial checkup, where the patient themselves can take the vital signs, so to help the nurses better manage their time using serving other patients. Another problem is that many patients in the ER departments come as a readmission, which means in less than 24 hours they come to the ER department, and then they leave, and then they come back in within 24 hours. There is in some hospitals the readmission rate is high. So we have a scenario here that says, in case of readmission, do not perform triage. It could help the waiting time. So anyone who would come as a readmission case, they will be admitted to the unit that they need right away without performing triage. But it could be a problematic, because some of them might need will go to the unit they need, and then the doctors will realize, oh, they actually need further help. We need to take their vital signs again, which will increase the waiting time and increase the crowding in the ER department. Another scenario is transferring triaged area to triage people to a waiting area number 2, in case the waiting area has reached its full capacity. Also using extension beds in case of full capacity in fast track. Another scenario is do not perform triage if transferred from respiratory zone, just admit them right away. And in case of, if there is a doctor that is actually free, but the beds or the rooms are full, we can let acute doctors reassess patients in the waiting area as a scenario. We can also limit access to ER patients only. What would happen if we don't allow visitors or relatives or any other people other than patients who actually need the ER? And last but not least, provide patients with access to the doors, instead of them having to wait for nurses to call their names. These are some of the scenarios that we're testing. Even if we don't take, or add any scenario, the simulation can help us in understanding as I mentioned earlier, the full capacity of the hospital. We can increase the number of patients per hour and see what exactly is the number that if we reach, the hospital wouldn't be able to operate as expected. Even if we don't change add any scenarios, or we don't change the maximum, the number of patients per hour, the simulation can help us in understanding the sustainability of the system, or the ER department. Would the hospital be able to operate as expected for 1, 2 more years, 10 years, or would there be a point in time where the hospital would not be able to operate as expected? Last but not least, the simulation can help us in resources reallocation. If we have a forecasting that says next week there will be a crowd on critical care, but not so much on acute care, we can transfer, for example, a doctor from adult acute care to critical care and see how would that impact the waiting time. It could indeed help the critical care to decrease the waiting time, but it could not, and it could possibly even increase the waiting time for the acute adult care. So it's worth it to test the resource reallocation in the simulation model before applying it in real world. Thank you very much.
Yeah, Ahmed, thank you very much for your presentations. So we're waiting for the questions appearing in our chat. So please feel free to write anything if you have any questions to the presenters. Also, I would like to remind you that you will also be able to ask your questions in the direct messages at the conference profile of the presenters. So please feel free to use this opportunity to have a conversation with our speaker. And I would like to say thank you to Mr. Ahmed for your presentations. Hope to see you in the discussions at our conference platform. So see you later, and thank you very much.
Thank you very much. Thank you for listening.